This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode number 850, recorded on January 6, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today right here at the incubator, Daniel Griffin.
Hello, everyone, and hello, Vincent.
Hi, Daniel. How are you?
Doing well.
Happy New Year.
Thank you. Yes.
The incubator, of course, is our recording studio in New York City, and it's easy for Daniel to get here. He's sitting right next to me across the table here.
Move into your
We have a big
there.
table. You can see the phage pillow behind me is shared by Daniel. Right.
Oh, this is great.
So, Daniel, this is update number 96. And before you start with your quote, I just wanted to ask you, before I forget, this is a question we've been getting a lot of. Omicron, does it cause serious COVID, or I should say severe COVID?
Severe.
Does it cause long COVID? Do we know?
So it's hard to comment on long COVID, sort of doing it in reverse, right? Because it hasn't been long enough. And we think of long COVID as lasting more than 4 weeks. But does it cause severe COVID? Certainly. When you look at these numbers and they say things like, oh, maybe it's 50%, reduction in hospitalization, maybe 50% reduction in deaths. So we're going from what? Instead of 2% of people dying, 1% of people dying. I had a gentleman I saw this morning, and he almost died last night. This is a gentleman in his 50s, unvaccinated, no other medical problems, but he made that decision not to get vaccinated. And he's producing, a thick, plasticky mucus in the lungs. Everyone tells me, oh, but Omicron doesn't really go to the lungs. In the hamsters, it's up in the nose. Well, this gentleman, I tried to explain to him how mild this was supposed to be. And, no, he coughing up thick, rubbery, nasty mucus. He's now on high-flow nasal cannula. We've done steroids. We've done TOSI. We're doing everything we can. And, it'll be, we'll see how he's doing tomorrow. But no, I had another woman who family decided she shouldn't be vaccinated. I talked to her. She seemed like she had capacity, so it would have been nice if she weighed in a little. But now she's on a morphine drip, comfort care. She's in the process of dying. No, people are dying of Omicron. 2,000 people on some days. Hospitalizations, as we'll talk about, are rising. I mean, there is severe disease. It's this whole issue when we compare a population that have been vaccinated, that maybe recently got through Delta. Maybe a bunch of the most vulnerable died in the first few waves. The people still around, the people still standing. You're going to see these impacts. And we'll talk a little bit about, is that due to any intrinsic change in the virus, or is it immunity? Is it different populations being impacted? But yes, Omicron causes severe disease.
So it's really a good point that the hamsters don't tell you the whole story, because they're not people and they don't actually get severe disease to begin with. So we're actually going to do that paper tomorrow on TWiV, but I think it doesn't give you the whole picture.
Yeah, I think you riled me up there,
It's good. Last night I was thumping on the table and someone said, "You're like a preacher," trying to make a point.
Yeah, we'll circle back to this. Don't you worry. So let me start with my quotation, and don't worry, we'll get right back into this. The single biggest problem in communication is the illusion that it has taken place.
That's great. I love it.
And so this has actually been attributed to a lot of people, but I do believe it was actually the Irish playwright George Bernard Shaw who actually said this initially. But maybe people can email in and let me know. So let's just start. Before I get into each section, I wanted to bring people up to speed. I think everyone is aware of the rising case numbers, but I do want to point out the hospitalization numbers are rising also, and the deaths. Right, we're seeing days with over 2,000 deaths per day. So where are we with the Omicron variant versus Delta? As far as the first of the year, the sequencing data we got from the CDC surveillance, we're at 95% Omicron. So it's almost all Omicron. And I always like to check, right? I don't trust anyone. Maybe I'm like Reagan, right? Like, trust with verification. Some famous quotation when he's talking about the Russians. But some of my colleagues are doing, sequencing for research purposes, doing hundreds of sequences per week. Yeah, we're in the 90s here in the New York region. So this I believe this data. This is consistent. As far as hospitalizations, right? Because everyone is trying to paint this rosy picture about this disconnect, this exact topic that Omicron's not so bad. It's the attenuated virus that the pharmaceutical companies could make. Go out there and get it for free. Don't. We peaked last January at about 128,000 hospitalized patients as a daily average, about 28,000 in the ICU. We're already up at 100,000 in hospital and about 20,000 in the ICU. And we have a lot of vaccinated people. So I'm having trouble with this narrative about how mild Omicron is. Here in New York, here in Long Island, COVID hospitalizations are rising rapidly. Vincent, you can actually see if you look over. This is what's happening locally. That's pretty mild, right? That exponential rise in hospitalizations. There's a disconnect from what I'm hearing in the media. Speaking to an NPR reporter earlier this week, and I was like, I'm so sorry. I mean, I know what you want to hear. I know what everyone's saying. But this is not something to be taken lightly. Omicron is causing severe disease. All
right. So the hospitalizations, you said some vaccinated people, but is the majority still unvaccinated people?
It's really, you can actually tell when I walk in the room. If someone's in the room and they're on non-rebreather, there are these high-flow nasal cannulas, they're requiring a lot of support, I pretty much know they're unvaccinated. So I usually sort of try to gently say, hey, so, any vaccines under the belt? They usually say no. That person who's on maybe just a little bit of oxygen or maybe not on oxygen, they've usually been vaccinated. So there really is a different presentation. Certainly, the other actually thing that I've started throwing in the mix, which I've seen, is I say, is this your first infection? Because we're seeing so many reinfections now. I'm actually taking care of individuals that I met for the first time back in April of 2020, now back in the hospital with COVID, again on oxygen because they did not take advantage of the vaccination opportunity.
All right, one more. So can you say, if you compare Omicron to Delta, whether there is more hospitalization in the vaccinated population comparing Delta to Omicron?
Yeah, I think it's hard to see a difference there.
Okay.
And then what I would love to see is just remove all the vaccinated people and just, with people who get infected who are not vaccinated, who never had a bout of COVID before, how are they doing? Is it really milder in them? And I think that's what people are trying to intimate. They're trying to suggest that there's a difference in the virus. And I think we need that data. You need to say, let's look at a population of unvaccinated individuals who got infected, and let's look at hospitalization rates, deaths in that population. That really answers the question, I think, is the virus behaving, in a less virulent manner?
Because as you know, Omicron is better at evading antibodies than Delta. And so I'm just wondering how that translates, if at all, into disease severity. And we don't know yet, but I think it's important to know because it tells you how important the neutralization is, right?
Yeah. And we're actually going to get to a paper which is rather interesting. I'll say the disconnect between waning antibody levels and rising protection against severe disease. So stay tuned. I know you're about to jump off, but don't go away. So let's talk a little bit about the literature here. So the research letter, Characteristics and Outcomes of Hospitalized Patients in South Africa During the COVID-19 Omicron Wave Compared with Previous Waves. This was published in JAMA. And there certainly are some limitations to this paper, but we'll go through that. So, one of the things they acknowledge is difference in age and comorbidities. But what did we see here? And I think this is one of those things that people don't realize. And when I point this out, they usually seem shocked. There's this perception that, South Africa, we're in Africa, nobody's vaccinated in Africa. Well, if you look at this paper, 44% of the adult South African population had been vaccinated as of December 2021, and greater than 50% of the population had evidence of previous exposure to SARS-CoV-2. Right, so this is not an immune naive population that saw Omicron. So in this context, let's go through. They have a wonderful table, and this is this is open access, so everyone can get to this. If you look at table 1, you can kind of see what happened. So, wave 1, about 4,000 people get admitted. Wave 2, 4,600 end up in hospital. Wave 3, right? That's the big Delta wave right before this. About 6,000 people end up in hospital. And then wave 4, 2,351. So less people in the hospital. So, the initial perception, right, is we're seeing less individuals end up in the hospital. They give us kind of numbers on this where they say, boy, during the previous waves, about 70% of people were admitted. During this wave, the Omicron wave, about 40%. So that's a nice reduction. That's very encouraging. But then you start looking a little bit more into the details. And actually, Vincent, I have this up in front of us so you can glance over because we're in the same room. If you look at, are these the same patients? Well, one thing we just talked about was, well, they're not the same patients in terms of immunity, right? We have ongoing vaccination campaigns. We had a recent Delta surge where a lot of people were recently infected, so they have memory of that Delta infection. But what about the age? And I think that's pretty interesting. In the previous wave, we were really looking at people in their 50s. This wave mainly impacted people in their 30s. I mean, age alone would almost give me this result. The other is the proportion of male and female. And in this wave, 61% of the infections were in females. We know women do better. We know they're less likely to end up in the hospital. What about comorbidities? In the prior waves, the majority of the patients had comorbidities. In this wave, only about a quarter of the individuals had comorbidities. So it really leaves me with a lot of sort of things to speculate about. So certainly this was better. Less people ended up in the hospital. Is this because we're looking at healthy 30-year-olds versus people over the age of 50 with comorbidities? Is this in part due to immunity, either that viral infection survivor immunity? And also, of course, the most vulnerable people have died in the previous waves, so we're sort of left with the survivors. Is it all the vaccination as that moves forward? Is it the female issue? Or I think everyone wants to say, oh, the virus has become less virulent. So, Vincent, any thoughts?
Well, you cannot make the conclusion because of all these things you pointed out, Daniel. It's not the same population. And in animal experiments, when we try to determine viral virulence, everything has to be the same. The same inoculum, the same animals, the same age, sex, and obviously that's very difficult to do in animals. And here it's impossible in people. So no, you can't say that. And then you throw in the immunity issue, and it's completely clouded. And so when they first said it's less virulent, I was doubtful. And now I'm convinced it's not.
Okay. All right. Well, we keep getting CDC guidance updates on quarantine and isolation, and this is a little bit contentious, so let me talk a little bit about it. In a sense, this happened backwards. They came out with these changes, and then they waited a while, and then they told us why, right? I mean, when you ask your children to do something, they might often, particularly my children, they'll ask why. We've taught them to do that. And you don't say, I'll tell you next week, but start doing this in the meantime, right? You want to know before you do it. Well, here's a couple things that they stated in the rationale. So the CDC came out with rationale. Why do we change things? And January 4th, the rationale came out. And let me go through what they said. COVID-19 cases due to the Omicron variant have increased along with seasonal increases in influenza and other respiratory viral infections. The potential for a large number of cases raises serious concerns about societal impact due to illness, as well as isolation and quarantine requirements. So that's sort of interesting. I mean, that was actually a lot of what I think Anthony Fauci sort of weighed in on is we've got to change something because we're about to enter a crisis, right? We think of ourselves as really critical in healthcare, but I think everyone realized how critical those pilots were, the air airplane mechanics, people involved in the food industry. I think a lot of us are essential. And so this was sort of a recognizing that we need to come up with some things. Otherwise, our economy is going to just grind to a halt. And it's not just about dollars changing hands. It's about people getting where they need to go. It's about people eating. It's about, all these other essential things. Then they go on to mention the data, right? I always like the data to come first, but that's okay. Data, including a review of 113 studies from 17 countries, show that most SARS-CoV-2 transmission occurs early in the course of infection. So, and I think this is true, and I think the data supports this. Infectiousness peaks around 1 day before symptom onset and declines within a week of symptom onset. So, we've been asking people to isolate for this big block of time. They don't necessarily know the 2 days before symptom onset, and we ask them to isolate for 10 days afterwards. Who's doing that? Maybe 20% of the people. It's not working. So what they were saying, and again, this is sort of what we'll go on to discuss, is that they are not saying at day 6 you're no longer infectious. This is actually a sort of, if you need to, this is an update, and this is a little bit of the science. But let's go through what articles did they quote. So the first one they quoted was actually published, very recently, September 17th, 2020. So that was a little bit back. I was a little surprised when I saw the date. But this was Transmission of SARS-CoV-2, a review of viral, host, and environmental factors. And it is a really nice review. I would have liked maybe a little bit of an update, more recent data, because they are saying they are basing this on what we know about Omicron. But there's a really nice figure 1. And I do encourage people to look at this. And there's really a lot in this figure 1. And I think we'll link this on the Parasites Without Borders page. But you can see this rapid ramp up in the amount of viral RNA in that day before symptom onset. You can see people entering that threshold of infectiousness. You can even see the correlation with the antigen test, which I'm sure we'll talk a little bit about. And then you can see how that PCR can just stay positive for prolonged periods of time, well past infectiousness. So, just sort of reinforcing that those PCRs, so many false positives as far as is their active viral replication, is their contagiousness, sort of, I think, really putting the PCR in its place. It's great for a sensitive test, but it's not great for asking this question, which we're talking about is, are you infectious?
Daniel, this is presumably an unvaccinated person, right? It's
unvaccinated, and it's not Omicron, and it's not Delta, right? Just look at the publication date.
Yeah.
So in a sense, it's old. And
it's likely to be very different in a vaccinated person, and depending on the variant as well, right?
I mean, we have a lot of data. We've talked about the famous Singapore study, and there's a number of other studies as well. It appears that a vaccinated person, they may shoot up as quickly, but almost like the Omicron wave, they drop right down very quickly. Yeah. So you almost need different isolation recommendations for vaccinated versus unvaccinated.
Let me point out here in this figure that by the time this period of infectiousness is really over, only shortly after that does the antibody go up. So the antibody plays no role in containing this. It's probably all innate immunity. So consider in a vaccinated person when the antibodies are going to rise in a couple of days, right? Mm-hmm. That's got to make an impact on infectiousness.
Yeah. And I don't know if people know as much about T cell kinetics, but the T cells are coming up at about day 3-4.
Yes.
So they're actually, you've got innate immunity, you've got T cell responsiveness. My PhD is in B cells, so let's be nice to them, Vincent. But this is not. This is really supporting the role of a lot of other arms of the immune system. All right. Also, they have another reference in there, and this is actually the comparative clinical performance of 4 SARS-CoV-2 rapid antigen tests and their correlation to infectivity in vitro. So that's another one to look at. So they're actually giving us their rationale. They're giving us the science behind this. This is really a moving forward. They then go on to say these data are from studies of prior SARS-CoV-2 variants. Some of the studies I looked at included Delta, right? So we're not talking specifically in these reference studies on Omicron. They do acknowledge the science is evolving, particularly for the Omicron variant. But then they go on to say that some of that data that is coming in now is suggesting, and this is consistent, I think, what we're seeing clinically, that Omicron has a shorter incubation period, 2 to 4 days, instead of that 7, 5, 4, which we've sort of marched through. And this is that time from exposure to the time that you're infected, infectious, and have symptom onset. And then a risk-benefit comment, right? This is not COVID zero. This is not a COVID zero. This is not the Taiwan approach where if you end up testing positive. Actually, one of my daughter's classmates went to Taiwan to visit his family and ended up testing positive on arrival. So he enjoyed his 14-day vacation in Taiwan in hospital, and then there was 2 PCR negatives required for him to leave. So this is not that approach. This is not a zero tolerance. This is a risk benefit. And they say the spread of the Omicron variant has the potential to worsen staffing shortages, increase supply chain challenges, jeopardize industry, education, and other systems that are essential to maintain a functioning society and economy. The pandemic has had a negative impact on the mental health of adults in the United States, largely due to economic and social concerns. And they go on to say the studies suggest that only a small percentage of people, they say small, but then they say 25 to 30%, isolate for a full 10 days. People were not following the old rules. They do also clarify that those masks, right? Those masks should be well-fitting. It's not just any mask. It's not just a bandana. If you are going to isolate for 5 days, if you're then going to go back to work on day 6, and the counting changed a little bit, you want to wear a tightly fitting proper mask. But they do say an estimated 31% of patients remain infectious. And here they reference a reprint mitigating isolation, the use of rapid antigen testing to reduce the impact of self-isolation periods. So they are acknowledging testing, and we'll even get a little bit more into testing as we go forward, because I know a lot of organizations have said, okay, this might be something we do in crisis mode, but as things get better, if we're going to let people out earlier, we're going to want negative antigen tests to reassure us that we're not sending infectious people into these settings. All right. So this next, I'm going to say Occam was not a physician. This is our flu-rona section. Please don't use that term. This was in the MMWR. This is characteristics and clinical outcomes of children and adolescents aged less than 18 years old hospitalized with COVID-19. 6 hospitals, United States, July through August 2021. Now, yes, children and adolescents are being hospitalized with COVID-19, thousands every week. With Omicron, this quote-unquote Omi-cold mild variant, no, this is not a mild variant. We have a rising number of children in hospital. Now, this was actually looking at over the summer. So this is prior to Omicron. This is July through August 2021. 77.9% were hospitalized for acute COVID-19. Among these patients that they looked at, approximately 1/3, so 1 in 3 of the youngest children less than 5 years of age had a viral co-infection. They had COVID and something else. Approximately 2/3 of those something else was RSV, which we've talked a lot on TWiV, and only 0.4% of the age-eligible children that were admitted were fully vaccinated. So I hope people got that. 99.6% of all these children that were admitted, age less than 18 years of age, that could have been vaccinated were vaccinated. So this is unvaccinated children being admitted. And I do want to point this out because people say, oh, but. 1/3 of these children were completely healthy, no comorbidities, no obesity, just completely healthy kids ending up in the hospital with COVID. And as we know, a third of those kids that end up in hospital end up in the ICU. So you can have COVID, you can have the flu, you can have COVID, you can have RSV, you can have COVID, you can have human metapneumovirus, one of my favorites. You could have, and we had a patient today with COVID and one of the common coronaviruses. So you can have it all.
What, you have names for all those, Daniel?
I think we need to make them the metapneumarona. I like that one. And I think the other, I want to acknowledge this, right? I had a gentleman who I'm still taking care of. He is getting better, but he got his COVID vaccines. He even got boosted, but he decided to forego the flu shot, right? Because there's not that much flu around. Well, unfortunately, this gentleman ended up getting influenza. Ended up getting admitted to hospital, ended up developing a staph pneumonia, so a bacterial pneumonia on top, ended up being intubated in the ICU. He's now extubated. He's on oxygen. But keep getting those flu shots and realize Occam was not a physician. You can have more than one thing. Okay. All right. Now we're actually going to get into our normal stuff. Children, COVID, and mental health, right? Children are at risk of COVID. We just discussed all the hospitalizations. And don't feel like this is a great time for your child to get Omicron. This is not something that you want to do willingly. We talked a little bit about the return to work guidance, but what about the return to school guidance? So we need to sort of compare these. So when the CDC shortened the recommendation to 5 days, if asymptomatic, following 5 days of wearing a mask when others are around, they then go on to update the quarantine guidance. And this got a little tricky, but it's going to be okay because we're going to get an update. They talked about unvaccinated, people more than 6 months out from their second mRNA, more than 2 months after a J&J, not yet boosted, right? So this had a lot of parents of younger children thinking, my child, though vaccinated, has yet been boosted. The eligibility had yet to open, but we're going to talk about that. They're going to end up having to quarantine again if there's a case at the school. But let's go through a couple of the updates that we got. And I have this in red in my notes. For people who need to quarantine, they recognize viral infection-induced survivor immunity for the first 90 days. This is the first time. So I know a lot of people out there, we've talked about in the UK, if someone gets infected, there was about a 6-month window. Here they're giving you 90 days. So that kind of counts. So I know people out there have been saying, why aren't we getting any credit? If you had confirmed COVID-19 within the last 90 days, so you tested positive using a viral test, but this doesn't cross over to the healthcare workers. But this is the first. And then this update, they added this testing option because a lot of people were really sort of frustrated. Like, what about testing? I don't really want people coming at it day 6. Maybe if you add a testing option, I might be more comfortable with that. And here we go. If an individual has access to a test and wants to test, the best approach is to use an antigen test toward the end of the 5-day isolation period. Collect the test sample only if you are fever-free for 24 hours without the use of fever-reducing medication and your other symptoms have improved. So just a couple comments. Loss of taste, smell may persist for weeks or months. You don't need to let that delay your end of isolation. If your test result is positive, then you should continue to isolate until day 10. If your result is negative, you can then end isolation, but continue to wear that well-fitting mask around others at home and in public until day 10. So this is making people feel a little bit reassured. But then again, nothing is 100%, and that's why they're saying even if it's negative, we're sending it out there, wear that well-fitting mask. Don't go hang around someone who's necessarily more vulnerable. And they also changed this definition of how to count 5 days. So I felt like I was in the days of how they counted malaria. So to calculate your 5-day isolation period, and I got to say, I don't completely agree with this, sorry. But day 0 is your first full day of symptoms. Day 1 is the first full day after your symptoms developed, and you can leave isolation after 5 full days. I usually ask people, like, was it in the morning? Was it at night? And I sort of count from there. But apparently, if you start getting symptoms at 1 a.m. in the morning, that's still day 0. If you got symptoms at 11 p.m., still day 0. You don't start to count that full day. So I'm not sure why the midnight sort of is calculated. But anyway, there's this new counting. So our HR department is really good at explaining this to people. And you're losing a day if your symptoms started, depending on what time of the day. But then, as we were saying, what about isolation of students or staff? Is this all apply to them? Actually, on December 29th, so after the 27th media release, we got some guidance. And here we have a person diagnosed with COVID-19 can be around others when at least 10 days have passed since their symptoms began. So still back at the 10 days for the staff and the schools. I'm not sure I understand this logic, sort of deprioritizing education. Maybe not. Maybe the suggestion is we have a lot of remote learning options. We're talking about doing this as sort of a one-time instead of 5 days, 10 days. But ultimately, this guidance, what people do, this is going to fall to the states, to your local school district. In New York, we still don't have a test-to-stay option. So this is going to be something that comes up to your local school. So we have a lot of guidance here. All right, let's jump ahead and boosters. Boosters for everyone, Vincent. Boosters for individuals 12 through 15 years of age on January 3rd, 2022. 2022, yeah. The FDA expanded booster eligibility, and then on January 5th, the CDC Advisory Committee on Immunization Practices endorsed. And I have to say, some of the children I know in the 12 to 15 years of age got boosted today. Actually, a couple brothers that I know, one of them did the vaccine vortex, the other did not. So this will be with an N of 2 whether or not that vaccine vortex really decreases that post-vaccination shoulder pain. All right.
Daniel, why did they reduce for the Pfizer 5 months from 6, but Moderna is still 6 months? Does it really make a difference, and can't they make it consistent so people don't get confused?
I actually think it would make more sense to make it consistent. Yeah, I'm not sure why Pfizer needs to be 5 months, Moderna 6 months. I do understand this concept, and we talk about this a lot, vaccine efficacy against infection. And our thought is that sort of is a 4-month window. So 5 months, I sort of see where that comes from. Moderna, interesting enough, if you look at the antibody kinetics, it actually does stay up a little bit longer. And actually, we'll talk about a little bit of a study coming up where maybe even Moderna is giving you a little bit better protection against severe disease. So. It just makes so much more sense to keep it all consistent. All right. Never miss an opportunity to test. As my wife says, this is a certain way to become bankrupt. A lot of people are overcharging for those tests. Please stop that. $50 for 2 tests in Port Washington at one of the pharmacies. So people are probably hearing about this. I wanted to make sure I touched on this. And this is this issue of, should I be taking that swab that's meant to go up my nose and stick it in the back of my throat before or afterwards, and then stick it up my nose, and then put it in and see if I can get something. So my friend Juan Potu, I call him Po, he's out at the Everett Clinic in Seattle. He was sharing a little bit of saliva testing turning positive prior to the Neris swabs. And there was an actual preprint. Saliva swabs are the preferred sample for Omicron detection. That was posted. I mean, I love when the title sort of tells you their agenda here. In this study, the authors looked at agreement between saliva swabs and those wonderful mid-turbinate swabs. Remember those brain biopsy ones that went back there? And they were finding higher levels of viral RNA in saliva with Omicron than Delta, but still the highest levels were in the mid-turbinate. We don't have timing data, so this will sort of develop and actually have the figure there, which I really like. So we're gonna learn more about this, and I think one of the challenges, no one wants to hear this, with different variants, we have to redo a number of our studies to really see. But the different tests, and there's been a warning about this, the tests are validated for collecting a sample from a certain area. So if your FDA authorized test is a Neris test, use it in the nares. If you really want to test the throat, you're going to have to use a test that was validated to work in the throat. And actually, there's a lot going on under the hood, as we say. So you want to make sure you use a test that's designed for procurement from that site. I don't know if you've been hearing much about this, Vincent.
People were asking last night on the live stream, is it better to swab the back of your throat? But really, saliva is doing that, right?
Yeah, saliva is a way of getting that.
But, we don't know how much of this is infectious or not. So is it just in terms of a sensitive diagnostic that we're talking about here? Because it's not about saying you're infectious or not, right?
Yeah, I mean, the middle turbinate, if you look at this data, even though they go ahead, they say saliva swabs are preferred. I'm not sure why they're preferred, because in the data that they show us, the CT values are always the lowest for the middle turbinate. Mm-hmm. So it appears more sensitive than saliva. So I'm not sure that the data supports the title. I like this idea of comparison. I don't know if you've heard the term mouth breathers, but maybe this is part of why everyone's getting Omicron, because the mouth breathers are talking and more virus in their mouth. I don't know, but that came to me in a dream, Vincent. All right. Active vaccination. Never miss an opportunity to vaccinate. And I'm going to add, we need to stop scaring the wrong people. We are clearly seeing with this Omicron wave that vaccines really do work to protect people against severe disease. And this actually, it's interesting because it says January 7th, but we're not there yet. So maybe I have this like a day early. But this is an MMWR. Risk factors for severe COVID-19 outcomes among persons aged greater than or equal to 18 years who completed a primary COVID-19 vaccination series, 465 healthcare facilities, United States, December 2020 through October 2021. So by the time this drops, this will be available for everyone to read. But here, this is great. The authors looked at 1,228,664 persons who completed primary vaccination for COVID-19. So they define this as 2 of the mRNA shots or 1 J&J shot. They reported that severe COVID-19 associated outcomes were rare at only 0.015%. Death only occurred in 0.0033%. Risk factors for severe outcomes included age greater than 65, immunosuppression, and about 6 other underlying conditions. All persons with severe outcomes had at least one risk factor, and 78%, so almost all of them who died, had at least 4 risk factors. So I want to try to put this fear in perspective, right? Prior to vaccines, we were seeing 10 to 20% of people who got infected end up in hospital, and we had a case fatality rate of about 2%. So we went from a 1 in 5 chance of hospitalization to about 1 in 10,000 with vaccination. Chance of death from 1 in 50 to about 1 in 30,000 with vaccination. And then I'm actually going to bring up the article because I want to go through this really interesting table. Because if you start looking at different things, and so I'm going to encourage people, go to this article. We'll post the link on Parasites Without Borders. But there is a table. And if you go through this table, on the far right, there's an adjusted odds ratio, right? So this is, can I do something that either increases or decreasing my odds of having a severe outcome? So I'm going to cruise on down to age, right? If you're over the age of 65, that's going to increase that risk. So we're going to say threefold, which sounds really scary, but your risk of death went from 1 in 30,000 to 1 in 10,000, which is still really low, right? Mm-hmm. You're over 65. Yeah. And remember, this is just 2 vaccines. Now, what if you decided to get my favorite vaccine, Moderna? You drop that risk almost in half. So your risk of dying is now 1 in 60,000. So not really sure you need to be living in fear, actually.
So this is through October, right?
Yeah, this
2021.
is through October.
So this is all Delta.
This is all Delta data. The other thing, and this is I love, what if you wait greater than 120 days? You're 6 months out. Your vaccine efficacy against infection is waning. The antibodies are going down. Wait, your chance of death just went down 30%. Your immune system is maturing. Now your chance of dying is even lower. So this doesn't make any sense, Vincent. The antibodies are waning. My vaccine efficacy against infection is going down. But in this population, their risk of ending up in hospital or death is actually being reduced. So I think this data has to be really reassuring. People who've been vaccinated, even without the boost, right? This is without the boost. Boy, the boost is just adding, sort of icing on the top of the cake. This is really reassuring data.
Does this mean that neutralizing antibodies are not so important?
Oh, Vincent, dare you say that? I think we're really having to break down this issue, and I think we have to break it down as a society as well. Vaccine efficacy against infection is one of those games that, what's the end game, right? This is Afghanistan. If our goal is to keep people from getting in the hospital, keep people from getting seriously ill, even to reduce the risk of long COVID, I think our vaccines are showing that they're really good at this stuff.
So antibodies will protect you against infection.
True.
But that contracts after 4 to 6 months.
Yes.
Yet you're still protected against severe death and disease, even when your neutralizing antibodies have contracted. So it's saying that either the memory response is enough, or memory plus T cells, B and T memory, must be enough to prevent severe disease, right?
Mm-hmm. I mean, this is very reassuring data, yeah. And I think does go along that line. So this whole fear of, oh my gosh, my antibodies are decreasing, oh my gosh, all these people are getting infected, this is really reassuring data with regard to just how tremendous these vaccines are. All right, passive vaccination. A lot of us are trying to ramp up to have EvuShield, just a little tip to our antibodies there. But a lot of what is changing the game is the access now, the availability of oral therapy. So now we move into the period of detectable viral replication. You start to get symptoms, you test positive. We now have some oral antiviral options, and they're available. We're using them. But I actually have encouraged a lot of the pro-health physicians to listen to this show this weekend, because I am getting bombarded with questions. So let me go ahead. Anuja, I'm going to tell people to just listen to this instead of answering those 50 phone calls an hour. So let's go through what are those options. So remember, we now have options for people who are at high risk of severe disease. So remember, sort of similar things we learned about with those monoclonal antibodies, over the age of 65, diabetes, immunosuppression, that obesity, renal failure, et cetera. And renal failure is going to come up. The drug that has the best efficacy from the trials is Paxlovid. This is actually nice. It's already in the Epic EMRs across the country. So you can actually type in PAXL and it comes down. And it's the Paxlovid kit, 150 milligrams, 2 tabs PO BID, with ritonavir, 100 milligrams, 1 tab PO BID. These 3 tablets are packaged together in a cardboard with sort of a push out. All 3 of those are taken together as a single dose in the morning, a single dose in the evening. Things to think about: renal adjustment. Kidney function's fine, you're good to go. But if the estimated glomerular filtration rate, our physicians will know what that is. If the kidney function is below 60 milliliters per minute, but more than 30, you could still use this medication. But what the pharmacist is going to do is they're going to pop out one of those 150 milligram tablets, and they're going to put a special sticker over the hole. So you're going to be taking, there's a special sticker, I've seen it. And then the person is going to be taking just 2 tablets, 1 Paxlovid, 1 ritonavir, twice a day. If the kidney function is below 30 for the estimated GFR, we're not sure about safety, so we don't recommend it there. The other thing that I want people to be thinking about, and you're going to be picking up a phone, you're going to be talking to the pharmacist, you're not going to be sending this off at this point. You want to know not only the patient's kidney function, but you want to know what other medications is my patient taking, because there are a number of medications that have interactions. Some of the statins are fine. Some of the statins are not okay, right? Those cholesterol lowering. Some of our chemotherapeutic agents, some of our opioids, some of our anticoagulants. So you're going to end up making a phone call, talking to the pharmacist. You need to know why the patient is getting this medicine, what's the risk factor. You need to know the other medications so you can make some decisions on what to do there. But it's okay. Two things can happen. One is the pharmacist and you may decide that there's a safety issue and that you don't want to use this medicine. Or what might happen is they might be out of Paxlovid, and the pharmacist will then say, we don't have Paxlovid, or if we decided not to use it, can we instead use molnupiravir? Molnupiravir, 200 milligram tablets, 4 tablets twice a day for 5 days. There is no renal adjustment here. There's no drug interactions. But remember, we don't want to use this in women of childbearing age. We don't want to give this to a pregnant woman. We're not giving this to children. So look in your area, right? In Nassau County, where a lot of our pro-health practices are. I've mentioned there's 3 CVSs, one in Glen Cove, one in Hempstead, one in Freeport. And you're going to basically need to know in your area which of your pharmacies has been selected as a dispensing pharmacy. And the nice thing is with a limited number of pharmacies, there's been a lot of training. So these pharmacists are going to really know what they're doing. They're going to help you work through this. All right. And now I'm going to jump all the way to the tail. And I like to remind people that COVID is not just a 2-week viral illness for many people. Unfortunately, individuals who've decided not to get vaccinated continue to be at high risk for this outcome. And this really is devastating. There was a nice review article published recently, Fatigue and Cognitive Impairment in Post-COVID-19 Syndrome, a Systematic Review and Meta-Analysis. And this article really resonated because I read this right after I was on a call with a disability reviewer regarding one of my patients who previously had been very high functioning and is still severely impacted. And I just can't imagine with their amount of cognitive dysfunction how they could return to their prior occupation. And in this paper, if you go to figure 3, I was trying to get everyone to read the papers, there's a nice view comparing the different studies, but ultimately they reported that about 1 in 5 individuals were having long-term cognitive impairment. And they assessed the cognitive impairment in several ways. They used performance-based cognitive function tools, so the Montreal Cognitive Assessment, the telephone interview for cognitive status, the screen for cognitive impairment in psychiatry, or in some cases there was a clinical diagnosis of the cognitive impairment. But this is really devastating, and as I point out, for a lot of people, this is a big push for the vaccinations, right? There's the case fatality rate, so there's deaths, there's hospitalizations, there's all the sequelae from that. But long COVID is here in the mix. Vaccines seem to do a great job of reducing but not completely eliminating long COVID. So I just want to comment on that as well. And then the WHO battle cry for vaccine equity. No one is safe until everyone is safe. We're going to continue through the rest of January to continue to collect donations to help support Microbe TV. Now that Microbe TV is 501c3, you can either go to parasiteswithoutborders.com, so go to parasiteswithoutborders.com, click on donate, and we will increase that money and support Microbe TV, or you can go to Microbe TV and donate directly. And the last thing before we get to emails is we are now going to have an internship opportunity.
Excellent.
So this will be exciting. We are looking for a global health coordinator intern. And this individual will need to be dynamic, committed, and have a passion for the global health, health equity, science communication, and our mission of addressing these with our educational programs. It's going to be a flexible, often asynchronous, but they're going to actually be coming to the incubator periodically. So it will need to be someone in the New York area. So if you're interested, send an email to daniel@microbe.tv.
That's right.
And send your CV, and we look forward to having you join us.
It's time for some email questions for Daniel. You can send yours to daniel@microbe.tv. The first is from Martin from the UK. Number 1, please can you advise on typical progressive dosing strategy with dexamethasone when COVID-19 reaches a stage where blood O2 drops below the 90s? I'd like to understand to what extent dosing is typically increased when a patient's O2 drops from low 90s into the mid-low 80s or worse. Is it normal practice to dose higher the greater the drop in O2? And if so, what dosing limits boundaries are typically observed to avoid risks of compromising the immune system's battle with the virus?
Okay, so this is great. This is very subtle, sophisticated, but I think important. So I know a lot of clinicians watch, so get out your pencil and take some notes. We've looked at what would be a standard dose, and I think in many ways we were lucky. It does look like dexamethasone, 6 milligrams daily times 10 days is in general a really good starting dose. We've looked at other studies where they've used higher doses. Doing that as a general is not great. Start with the 6 milligrams, and then we see how they do over the next day or two. If they continue to progress, if the oxygen requirement escalates to, let's say, a non-rebreather, the high-flow nasal cannula we've talked about, then we will often escalate to 10 milligrams, so dexamethasone 10 milligrams per day. We will at that point often jump in with tocilizumab. 10 milligrams is really what we'll do, but then becomes the issue when you reach day 10 at that 10 milligrams. Do you continue for a period of time? And do you gradually taper? And that becomes an individual management decision. But starting with 6 milligrams, if you want to escalate, jumping up to 10 milligrams, considering adding something like tocilizumab in there, and then continuing out to day 10 and making that decision. Making that decision at day 10 is going to really depend in many ways on where you are in the world. If I'm doing my consultations in Bangladesh with all the concomitant parasitic issues, we're really careful going past day 10. But in a lot of other settings, you may continue, you may slowly bring it down, but you're going to be following neutrophil lymphocyte ratios, ferritin, other markers for that guidance.
And the second question, are you reasonably comfortable with substituting methylpred, prednisone, prednisolone, or do you stick rigidly with dexamethasone?
No, actually, there are some studies, sort of head-to-head comparison supporting the use of methylprednisone. Solumedrol, some of the other formulations, even prednisone instead of dexamethasone. No, you don't need to specifically just use dexamethasone. There's a lot of data out there supporting alternatives.
Next one comes from Nolan, who is at the National Institute of Environmental Health Sciences, and he writes, I've been thinking about your scaring the wrong people formulation. I agree many of the stubbornly unvaccinated are not going to be persuaded by new data, while the boosted and masked remain in a state of anxiety. I think the PTSD being experienced by the latter is caused by an inability to address one's risk once you've taken the basic precautions, vax, mask, test, distance. This is exemplified by people asking about a 4th or 5th vaccine dose. Epidemiology shows obesity to be a major risk factor for COVID outcomes. Working on your BMI is something you can do alone or with your PCP. Personally, I've been doing my best to get my BMI out of the COVID danger zone since this pandemic started. I appreciate PCPs are regularly asking their patients to lose weight. This may seem outside of TWiV's interest, but the extra motivation of avoiding bad COVID and giving people the agency to get their worries under control might be effective. 2 birds. Additionally, we now have some mechanistic data indicating SARS-CoV-2 might be infecting adipose tissue and causing local inflammation, which begs the question whether viral replication and inflammation might scale with large deposits of fat. And Nolan provides a few references for papers on that. Surgical means of weight loss also help and provides a JAMA paper for that. Thanks for your thoughts.
So this is great. And actually, I've seen a lot of those studies. I find them really interesting. I'm hoping that the MMWR release that we talked about gives people some sort of concept, gives people some sort of a number of the risk post-vaccination. We are scaring the wrong people. And for a lot of individuals, if they've been vaccinated, they could really calculate what are these risks. And, risk calculations are sort of tough for people. But yeah, we're scaring the wrong people. People who are vaccinated are in really good shape. People who are unvaccinated, you can't talk someone out of a position they were not talked into.
Alan is an MD at the Bronx VA Medical Center. He writes, as COVID-19 evolves, your podcast becomes even more relevant to clinicians. My questions relate to the choice of therapy for COVID for a patient with moderate disease who has risk factors, such as age greater than 65 or obesity. If either Paxlovid or sotrovimab were available, which one would you prefer? I will also assume the patient would be willing to come in for the infusion if this was the better option. Do you see a role for combination therapy for immunocompromised patients?
So that's perfect, and that has come up in the last couple of days because we've had exactly that choice. So TWiV, which is the Vir-GSK monoclonal antibody that is effective against the Omicron variant, it is available in incredibly limited supply. But let's take a person who might qualify. I've sort of got people stratified. So let's say this is a renal transplant, an organ transplant patient, immunocompromised at high risk. One thing you'd say, oh, why don't we just give them both? But there's limited supply, so we're not recommending that. If you look at the data on the Paxlovid, you can very quickly get that into a person, 88, 89% reduction in progression. If you're within the first 5 days, the data is a little bit stronger, I'm going to say, on Paxlovid. This was not head-to-head, right? So we're sort of hedging there, a little bit stronger. But there's a window here. Let's say it's day 6. We might go with sotrovimab. But it's a really easy lift to get people on the Paxlovid, on the oral agents. There is a little bit of a sense, right, that the Paxlovid might be superior. But there's another side to this, and I think this is reasonable for discussion, is the Paxlovid is only going to work for those 5 days. The sotrovimab is going to actually be in the system probably for many months. So I think you want to make an individual assessment with your patient, particularly a patient like that. Let's take someone who can't really generate a lot of their immune response. You may not only be addressing the acute issue, but you may be giving them that prophylactic antibody protection for months ahead.
And the last one from Marcia. My daughter-in-law had her 2 jabs prior to getting pregnant. Now she's halfway through her pregnancy, due on Mother's Day. Just over 6 months since her last jab, her OB doctor doesn't want her to get a booster as he is worried about the booster vaccine affecting the fetus. I believe she should get the booster now, but I can't overrule her OB doc. They have a 2-year-old and a 3-year-old, and I want all of them to have protection. COVID is not a good thing in pregnant women. Where do OB docs get their information about giving boosters to their patients? He said he's checking into this. We think he's a good doc. He delivered her first 2 children. What do you think? Can you let me know?
Sure. So I'm going to suggest that maybe you can send a link to this podcast, to this OB, because we are seeing a lot of this. There was a recent study really showing how incredibly safe vaccinations are during pregnancy. We also know that pregnant women are at a much higher risk. And the other thing is that if a pregnant woman gets vaccinated, not only are they getting a certain amount of protection, but there is passive antibody and passive cellular protection for the newborn. So getting vaccinated during pregnancy is the right thing to do as a mother. It's the right thing to do to protect your unborn child. And as we know, if a woman gets infected with COVID during pregnancy, this is the unvaccinated data, they're at twice the risk of losing that baby. So you really want to get vaccinated.
That's COVID-19 Clinical Update number 96 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, Vincent. And thank you, everyone. Be safe out there.